Good morning, everyone. Today we are going to discuss the role of TE in aortic surgeries. Coming to the basics, we'll discuss the basic TE views to visualize thoracic aorta. The views which are used to visualize ascending aorta are mid-esophageal ascending aortic short axis view, mid-esophageal ascending aorta long axis view. We'll start with the first mid-esophageal ascending aortic short axis view, which is obtained by withdrawing the probe from mid-esophageal aortic valve short axis view and rotating the transducer angle back to 0 degree. So this is the view. We can visualize ascending aorta along with SVC, and we can see pulmonary artery, main pulmonary artery, along with the branch PA, which is RPA. And the second view to visualize ascending aorta is mid-esophageal ascending aortic long axis view, which is visualized from mid-esophageal aortic valve long axis view by withdrawing the probe and turning it to the left and decreasing the transducer angle to 100 to 110 degrees. So here we'll see the wall of ascending aorta which are parallel to each other, and in short axis we can see pulmonary artery, which is right pulmonary artery. In systole, it will appear red through the proximal and blue through the distal ascending aorta. In late systole and early diastole, flow will be in opposite direction to facilitate closure of aortic valve. Turbulent systolic flow will suggest aortic stenosis, while continuous flow during both systole and diastole will indicate aortic insufficiency. So we can see any aortic pathology like atherosclerosis, dissection, aneurysm, aortic insufficiency flow, AS flow, PA catheter in RPA, and also pulmonary embolism and pericardial effusion. T imaging of aortic arch. So basically the aortic arch is often obscured by interposing air-filled trachea. So most optimal view of aortic arch are obtained by withdrawing the probe from mid-esophageal ascending aortic short axis view at 0 degree and rotating it to left to obtain upper esophageal aortic arch long axis view. So this is the upper esophageal aortic arch long axis view, showing the proximal part as well as the distal part of the aortic arch. So it will be obtained by withdrawing the probe from mid-esophageal ascending aortic short axis view and rotating it to the left. So it will show the proximal arch followed by mid arch and the great vessels and distal arch before it joins the proximal DTA. Flow will appear red through the proximal part and blue through the distal arch, and continuous flow during systole and diastole in aortic arch would suggest aortic insufficiency. Then coming to the upper esophageal aortic arch short axis view at 70 to 90 degree, we get it. So from upper esophageal aortic arch long axis view, if we increase the diameter to 70 to 90 degree, we'll get upper esophageal aortic arch short axis view. This will also show the proximal origin of left subclavian artery and innominate vein in the right upper display. So this is that view which will show the RVOT, pulmonary valve, main pulmonary artery, and in the short axis we'll see aortic arch and innominate vein. So these are the various structures which we can visualize, including the pulmonary artery and left and anterior cusps of the pulmonary valve. We can measure the pulmonary valve annulus in this view. We can also see PDA in this view. Now coming to the descending thoracic aorta, the view which could be used to visualize it is descending aortic short axis view, which is obtained by turning the probe to left from mid-esophageal 4-chamber view. So this is our descending aortic short axis view. We can see left pleural effusion also, IABP tip position in this view as well, and can see aortic insufficiency severity in addition to atherosclerosis, dissection and aneurysm. Then descending aortic long axis view, when we from descending aortic short axis view, when we increase the angle to 90°, we'll get this view. Distal aorta will be on the display on left side and proximal on the right side. Wall of the aorta should be parallel. Flow will appear red through the proximal part and blue through the distal part. This is our descending aortic long axis view. These are various subdivisions of aorta which is done in CT, views obtained by CT from 1, 2A, 2B, 3, 4A, 4B, 5A and 5B. So this is what are the CT views. So here is the aorta showing the aortic valve annulus, then sinuses, sinotubular junction, brachiocephalic trunk, aortic arch, left common carotid, left subclavian, then descending aorta, and it is also telling about the normal sizes of various parameters like annulus, sinuses, STJ, arch. So how to measure the aortic annulus, which is very important. Aortic root consists of the aortic valve annulus, aortic cusp and sinuses of Valsalva's. Normal aortic diameters will vary according to location and gender. Now, aortic annular diameter should be performed using inner diameter along the hinge points of aortic leaflet during systole. Annulus is circular, but it becomes elliptical in older adults, and measurement should ensure the maximal aortic diameter in a plane parallel to the long axis of aorta. European Association of Echo and ASC suggest leading edge to leading edge measurement during end diastole of remaining aortic segments. However, with recent improvements in echocardiographic imaging, difference between leading edge to leading edge versus inner edge to inner edge measurements are minimal. All measurements should be performed to the long axis of aorta. Sinuses of Valsalva diameter should be measured from anterior right coronary sinus to one of the posterior sinuses, which is usually non-coronary, and the largest diameter should be sought, which is parallel to aortic annulus and perpendicular to aortic long axis. So these are the various methods. So leading edge to leading edge to trailing edge, and trailing edge to leading edge. So these are the way. This is midesophageal long axis view, where we can see the aortic annulus, the cusps of the aortic valve, sinuses of Valsalva's, and STJ and ascending aorta, and all these diameters are measured here, and it is shown in this figure. It's how this diameter should be measured along, perpendicular to the long axis of aorta. These are the normal dimensions of root and ascending aorta and mid-descending aorta and diaphragmatic aorta. Then we are coming to aortic aneurysm. An aneurysm or true aneurysm is a localized dilatation of at least 50% encompassing all three layers, including intima, media and adventitia, while ectasia is arterial dilatation less than 50% of the normal artery. In ascending aorta, 5 cm is considered the threshold for aortic aneurysmal disease. As opposed to other modalities, TE is considered a third line recommendation for the evaluation of thoracic aortic aneurysmal disease. While it's an excellent modality for evaluation of aortic insufficiency mechanisms and the aortic root, proximal ascending aorta, arch and descending aorta, it has many disadvantages compared with CT and MRI. Distal ascending aorta and arch vessels are poorly visualized and landmarks are limited. Mechanism of AR should be elucidated. A common mechanism for functional AR is tethering of AV cusp as a result of mismatch between aortic valve annulus and STJ diameters. This tethering results in a retraction of aortic valve cusp, insufficient leaflet coaptation and hence regurgitation. The echocardiographic determinants of functional AR with anatomically normal aortic valve include a coaptation leaflet height, that is the maximum distance between the point of coaptation and annular plane. If it is greater than 8 to 10 mm, and STJ to annulus ratio greater than 1.6. So that is the criteria for the functional AR. With repair of aortic aneurysm, there may be restoration of aortic root geometry with improved leaflet coaptation and a decrease in severity of AR. So that is how we should assess functional AR. We should see coaptation leaf height, we should see STJ to annular ratio, and if we think that AR is functional, then simply repairing the aneurysm will decrease the severity of AR. This is a functional AR image showing functional AR secondary to ascending aortic aneurysm. So this is a mid-esophageal aortic valve long axis view. Here we can see the sinuses of Valsalva. They are enlarged. They are huge with respect to the annulus, and this results in the aortic valve tethering, and the coaptation plane of aortic leaflet is significantly distal to the plane of aortic annulus. Aortic atherosclerosis. Thoracic aorta is a potential source of emboli since it contains atherosclerotic plaque and may be instrumented multiple times during cardiac operation. So, these lesions may protrude into vessel lumen, be calcified, and compromise the integrity of the valve. They are most common in abdominal aorta, followed by descending aorta and then ascending aorta. TE may provide information on plaque mobility, ulceration, and composition. This is a grading ASA 2015 guidelines, which describe 1 to 5 grades, and there is one description by CATS. So from normal to complex. So if intimal thickness is less than 2 mm, it is grade 1. If it is 2 to 3, it is grade 2. If it is 3 to 5, it is grade 3. If it is more than 5, it is 4. And if it is mobile, it is 5. Distal ascending aorta and proximal aortic arch isn't visualized consistently on TE because of the atherosclerotic plaques in visualized portions increases likelihood of disease in non-visualized parts. The sensitivity of TE for detection of distal ascending atherosclerosis may be substantially increased by introduction of saline-filled balloon into trachea and left main bronchus. This will allow the visualization of distal ascending and proximal aortic arch. So aortic dissection, the sensitivity for detection of aortic dissection is 88 to 98% with specificity of 90 to 95%. As compared to CT and MRI, it's portable and doesn't require ionizing radiation. An examination can be performed within 15 to 20 minutes and diagnosis can be made. Dissection flap will have an independent motion compared with surrounding structures, and intimal flap should be contained within the aortic lumen. Color flow Doppler should be used to identify two separate flow patterns within each lumen. Flow should not appear to pass easily through dissection flap. True and false aortic lumens should be identified. The false lumen is typically larger and it expands during diastole. Flow in false lumen may be absent, delayed, or reverse, while flow in true lumen is laminar. The slower flow may be seen as a spontaneous echo contrast or thrombus. Intimal tear will appear as a break or continuity. Ideally, the specific location of entry and exit sites are also identifiable. During systole, there is a flow through the intimal tear from true lumen into false. The identification of site of intimal tear may be made in 78 to 100% cases by T. It's important to differentiate main intimal tear from smaller communication. It's frequently located in proximal part of ascending aorta in type A dissection and immediately below the origin of left subclavian artery in type B. Multiple smaller secondary communications can be appreciated in descending aorta that may correspond to origin of intercostal or visceral arteries. T can identify complication of aortic dissection like AR, pericardial effusion, pleural effusion, LV dysfunction, secondary to involvement of coronary artery in dissection process. So this is what we have to do. We have to identify the intimal flap, dividing it into two lumen. We should define the extent of dissection flap and true and false lumen in the aortic root. We should identify true lumen which will expand during systole. There will be diastolic collapse and systolic jet directed away from lumen and absence of sec and forward systolic flow, while false lumen, the diastolic diameter will increase, spontaneous echo contrast or thrombus, or there is a reverse delay or absent flow. We should also identify any thrombus in the false lumen, entry and exit tears, assessment, presence, severity, and mechanism of aortic insufficiency. So valve we should identify whether it is bicuspid, degenerated, normal, with or without prolapse of one cusp, dilatation of different segments of aorta, flap invagination into the valve, severity by classic echocardiography criteria. We should assess coronary artery and involvement if it is going into coronary ostium and obstructing the ostium, if there is an absence of coronary flow or new RWMA, if there is any side branch involvement, pleural and pericardial effusion we should identify, and any signs of pericardial tamponade. So this is an intimal flap in midesophageal ascending aorta long axis view, which is seen extending from STJ through the ascending aorta. This is another in short axis view with the true and false lumen. This is a primary descending aortic long axis view. So immediately distal to left subclavian artery, we can visualize dissection flap with blood flow from the true lumen. The blood flow we can see going from true lumen into the false lumen. In the figure A and B, there are very smaller communications from true lumen to false lumen. So this is it where dissection flap is going in, and but in the C figure it is going into the LVOT. So we must identify mechanism of AR. Most common is dilatation by false lumen with the resultant leaflet tethering resulting in incomplete coaptation and functional regurg. If it extends proximal to STJ into sinuses of Valsalva, the aortic valve commissure may become disrupted from aortic valve, and if it is disrupted, aortic leaflets are not suspended from STJ and they prolapse with resultant AR. If there is a long complex dissection flap may prolapse through the aortic valve and interfere with normal aortic valve function, and pericardial effusion is common. Most common is the transitation of fluid across thin wall false lumen into pericardium, or aorta can rupture also. Compromise of coronary blood flow may result as a result of expanding false lumen, which can compress proximal coronary artery or by extension of dissection flap. Color flow Doppler may detect presence or absence of concerning CAF, and RWMAs may provide information about the concerning CPF. T can also detect aortic intimal intussusception, and major limitation of T is appearance of reverberation or mirroring artifact that may appear as intimal flap. They are most common in dilated ascending aorta. So these are the reverberation artifacts which may mimic false lumen. The left innominate vein in this is visualized along the lesser curvature. So injection of saline in left upper vein will demonstrate spontaneous echo contrast. So it may appear as a false lumen, but it is a left innominate vein. Then there are intramural hematoma and penetrating ulcer, as we can see in this figure in midesophageal ascending aortic long axis view and short axis. An intramural hematoma is seen in the posterior and the rightward portion of the ascending aorta from the aortic root extending to distally, and as opposed to atherosclerotic changes, it is crescent shape. This is a penetrating aortic ulcer in the inferior aspect of aortic arch. It is characterized by outpouching of the aortic valve. During IABP placement, again we have to see that the distal tip does not include. This is just another use of TE which we can use during IABP placement intraoperatively by using descending aortic short axis view and the long axis view. Even during TAVR, TE is important. We can provide exact vessel and lesion sizing and localizing, which is difficult to obtain during single plane angiography. Especially in type B dissection, to ensure the wire and delivery device remain in true lumen, we should distinguish stent graft from delivery system, and it ensures that endograft bridges the diseased aorta. TE can only be used between fluoroscopy because of interference it causes during fluoroscopy. Exclusion of flow from aorta into aneurysm after stent graft placement can be confirmed by color flow Doppler, and sensitivity and specificity of TE for endoleak detection is 100%. So this is the endovascular stent graft delivery system in the first figure, and it is seen being advanced into descending thoracic aorta through a pseudoaneurysm, and after the deployment on the right side there is excellent flow exclusion of pseudoaneurysm with a patent intercostal artery. This is an endoleak which has been demonstrated between two portions of aortic endograft that was not visualized by angiography. As we discussed, the sensitivity is 100% for detecting an endoleak, and this is the upper esophageal short axis aortic arch view. Thank you.